For 3 consecutive years, the United States has recorded more than 100,000 overdose deaths. That figure is often repeated as a headline number, but it obscures the churn underneath. Periods when prevention and treatment gain traction, when death curves bent downward, followed by reversals driven by policy retreat, fragmented execution, and the steady evolution of a more toxic drug supply. This episode is about those reversals. It is about what happens when a hard-won advance is met with a cut, a lapse, or a shrug, and why the consequences of less in an overdose crisis reliably become more funerals. After years of incremental improvements in local systems, more naloxone in more hands, emergency departments starting medication for opioid use disorder at the bedside, probation officers trained in harm reduction, and counties building basic data dashboards, fatalities dipped in several regions. In practical terms, that meant fewer midnight calls to parents, fewer classmates attending memorials, fewer outreach workers carrying grief into the next shift. It showed up in quieter ways too. A person who had overdosed twice in 6 months suddenly appearing every Monday at a primary care clinic to pick up buprenorphine. A small encampment beginning to thin because a mobile team moved people into rooms and kept them there long enough for the first paycheck to arrive. Then the backsliding began. Budgets were tightened. Grant-funded pilots that had proven their value were allowed to sunset. The rhetoric of priority persisted while the line items eroded. Insurers shaved rates or narrowed networks. A federal payment rule lowered reimbursements to the clinicians most likely to see people with addiction. Local programs that had stitched together fragile continuums, street outreach to clinic to housing, lost one stitch, then another, until the fabric gave way. The human translation of 3% less, or pilot concluded, is not abstract. It is a missed follow-up call because the peer on the team was laid off. It is a 2-week wait for an intake because the clinic cut hours. It is an ER discharge with a pamphlet instead of a same-day appointment because the bridge clinic closed at 5 on Fridays to save overtime. When the margin of safety shrinks in a system confronting a toxic supply, the outcome is preordained. More people slip, and more slips are fatal. Cutting capacity does not only reduce access, it changes behavior. When people believe a door will be closed when they knock, they stop knocking. Trust is an outcome that must be produced and maintained. It cannot be turned on and off with a funding cycle. In places where warm handoffs were once reliable, word traveled quickly when those handoffs failed. People returned to what was reliably available: the street economy, the friend with pills, the powder of unknown provenance, because the system's reliability had been allowed to decay. A second reversal came from leadership drift. Coordination that had been painstakingly built across health, housing, justice, and labor evaporated when the convening authority stopped convening. The weekly calls became bi-weekly, then monthly, then as needed. Without a standing table, where problems are put down and solved in shared view, silos quietly reassert themselves. Outreach learns on Monday about a motel housing program that closes on Wednesday. The jail clinic learns in retrospect that Medicaid reactivation stalled for 2 weeks after release. Each unit continues to work, but the system stops working as a system. A third reversal came from measurement fatigue. Dashboards that once drove daily action turned into quarterly reports. The distance between a red alert and a field response widened. In the absence of live metrics, decision-makers defaulted to narratives. Who is upset? Whose emails are loudest? Rather than the pattern in the data. The overdose heat map kept changing. The resource map did not. All of this happened in the shadow of a drug market that changed faster than any budget cycle or procurement rule. Synthetic opioids have compressed the timeline of risk. What once unfolded over years, rising tolerance, deteriorating health, mounting consequences, now collapses into months or even weeks. Potency, adulteration, and volatility make small gaps lethal. That is why 3% less in the places that matter, street outreach, same-day medication starts, housing that does not eject people for relapses, translates into outsized harm. In a toxic environment, the distance between sufficiency and catastrophe is measured in inches. What then does it take to stop the backward step? First, ring-fence the essentials. Naloxone supply, same-day access to medications for opioid use disorder. Contingency management and counseling supports, syringe services, post-overdose outreach, jail-to-community handoffs, and low-barrier housing are not pilots. They are public safety infrastructure. Fund them the way we fund fire departments, predictably across years, insulated from routine austerity. Tie growth to outcomes, but do not expose the base layer to annual attrition. Second, make continuity non-negotiable. No warm handoff, no discharge. If the emergency department cannot reach the clinic, the hospital is the clinic until the handoff is complete. If the jail cannot confirm coverage is active, the jail carries medication through the gate, and the case manager meets the person at the curb. Build the expectation that a person moves through an unbroken chain and enforce it with the same seriousness used to enforce surgical checklists. Third, keep the table set. A standing interagency council is not a mood. It is a machine. It meets at a regular cadence with an agenda defined by metrics. Time to treatment, 30, 90, 180-day retention, overdose reversals by neighborhood, rearrest rates following treatment, housing stability, and employment starts. When a number goes the wrong way, someone is assigned to own the fix, with a deadline measured in days, not quarters. The council's job is not to describe the crisis. It is to change the numbers. Fourth, preserve speed. The drug supply will continue to mutate. Budgets and procurement must allow for rapid reallocation, moving outreach to a new corridor, adding capacity to a clinic experiencing a surge, deploying test strips or xylazine-related wound care where the data show an emerging threat. A slow system is a permissive system for death. Finally, communicate reliability. People use systems they trust. Trust grows when the promise is kept repeatedly. There is help today, at this location, without judgment, without intricate paperwork, and without punishment for being ill. Every failure to keep that promise echoes beyond the one person who experienced it. Every kept promise echoes too. 1 step forward, 3 steps back is not a fate. It is the predictable result of shrinking the very points in the system where time, trust, and continuity are produced. The antidote is managerial courage to protect capacity, to insist on handoffs, to measure what matters every week, to hold someone responsible for every number on the screen, and to treat life-saving services as infrastructure rather than experiments. The nation proved in small pockets that deaths can fall. The task now is to stop unlearning the lesson.